public policy advisor and advocate and sometimes lobbyist in Washington, D.C. I've been doing that for a number of years, and before that I spent 10 years on the House and Senate Aging Committees. It's my pleasure to be the moderator of today's session and to introduce our colleagues here. The session today is the merging of three very important pieces of what I'd call the advanced care illness puzzle. We're going to address three areas. What is person-centered care, and what happens when we fail to provide it? How do we get the right amount of treatment and avoid unnecessary or unwanted care? And finally, what kind of political and policy environment is needed to move an advanced care agenda? We have three very impressive speakers, and they will address those issues. First, Lynn Friss Feinberg, who's a fellow social worker, is a senior strategic policy advisor at AARP. She works in the Public Policy Institute and is part of the team on independent living and long-term care. Prior to AARP, she was the director of the Campaign for Better Care at the National Partnership for Women in Washington. And before that, from 1985 to 2009, Lynn worked with the San Francisco-based Family Caregiver Alliance. Many of you probably know of their good work. Those of us from the Washington, D.C. area also remember Lynn's excellent work on Senator Barbara Boxer's office as a staff member there and as a Heinz Fellow in Aging. Our second speaker will be Mickey McIntyre. He serves as the Chief Program Officer of Compassion and Choices, and his job is to set and guide the strategic direction of the organization, and that includes their advocacy work, their consultation programs, their education, and outreach. Mickey has committed his career to social change and has helped build nonprofit civil rights organizations prior to coming to Compassion and Choices. He's an expert at fundraising, organizational development, and coaching nonprofits through their strategic planning. So he's someone we all could probably use some counsel with. Andrew McPherson will be our third speaker today. He's the Director of Government Affairs at Jennings Policy Strategies. Many of you know of Chris Jennings, who served as President Clinton's healthcare advisor. Chris and Andrew provide major players in Washington and across the country in the healthcare world with advice on healthcare policy, legislative strategy, and communication techniques. Andrew works with clients including consumer groups, labor, business, public employers, and foundations. Andrew and I have spent a good bit of time working in the last couple of years very closely on the development of a relatively new coalition in DC called CTAC, and he'll tell you about that today as well. So I'm hoping that you all noticed that I took the St. Patrick's Day rule very seriously. More than 50% of our speakers today are Irish, and I don't and Swedish. Yeah. I don't know all of your background, Lynn, so if you want to fill that in, feel free. So we'll start with Lynn, and I won't do any additional remarks. We'll do Q&A at the end, so we make sure everybody gets their time to speak. Thank you.
Thank you, Brian. Good afternoon, everyone. How are you? Doing well? Good. I am not Irish, but I'm looking forward to seeing the river turn green tomorrow in Chicago. It'll be fun, and the parade is supposed to be awesome, so I hope you'll all stay. I'm very pleased to have the opportunity to talk for a few minutes with you today about an issue that's near and dear to my heart. And the bottom line, my big takeaway that I'll tell you up front is that serious illness and chronic disability affects the family as well as the older person. And we need not only to focus on person-centered care, but family-centered care. And yesterday, for those of you that were at the general session in the morning, Monsignor Fahey and Ken Dykewald both reminded us of something that Maggie Kuhn, the founder of the Grey Panthers, said many years ago, and I was really struck by that in terms of what we're talking about today. And Monsignor Fahey said that Maggie Kuhn had said, we put too much emphasis on independence in old age. It is really all about interdependence. And that's really the notion of person and family-centered care. Caring for someone we love with advanced illness or frailty in body or mind is the most personal experience that we can live through. This is the subject of family caregiving, and it is becoming more widespread across our country as baby boomers like myself care for their parents in frailty and in end of life. And I was also struck that Monsignor Fahey also talked about not necessarily using, maybe we can get into that, the words of advanced illness care, but really talking about end of life and saying death. Ken Dykewald kept saying, okay, I won't say passed on, we're going to talk about death. But language matters, and are we talking about patient-centered care or person-centered care? So traditionally, the term person is used in long-term services and supports, in home and community-based care, but the term patient really comes from the healthcare side of our world. The term person, rather than patient or patient-centered care, is, in my view, preferred because it really looks at the whole person, including the family where appropriate. It emphasizes continuity of care, quality of life, and looking beyond the medical and healthcare needs of the older adult to the interdependence of family and friends, to community, to spirituality, to our lives with our churches and our synagogues. And that Maggie Kuhn really understood in terms of the notion of interdependence as opposed to autonomy as the guiding principle. And it was also part of the discussion this morning at our general session on global aging, talking about the importance of community in the lives of older people and their families. I would suggest that the term person-centered care alone does not adequately capture the importance of families in the lives of older people, particularly at end of life. The family, as we know, is the main source of help for older people with functional limitations in daily life, including advanced illness. Family caregivers of adults with chronic health conditions provide an estimated 40.3 billion hours of unpaid care a year, valued by the AARP Public Policy Institute at about $450 billion a year. What that means is that if family caregivers went on strike for a day and decided we're not going to do this anymore, it would cost our country and our society $450 billion to replace that unpaid labor. And it's also important to know that more than 75% of people at end of life are unable to make their own care decisions and do rely on their families. Like the person-centered care model, person and family-centered care focuses on the person and also considers his or her needs, goals, preferences, cultural traditions, family values, and the family situation. Person and family-centered care also recognizes and addresses family needs and preferences and supports the family in the plan of care. This view of person and family-centered care sees family caregivers as individuals in their own right, not just as resources for the older adult, as individuals that need their own care and support, particularly during end of life. Care for people with advanced illness should be centered on what the person and the family need and want. As Don Berwick, our former CMS administrator, said, the concept of person and family-centered care shifts control and power out of the hands of those who give care into the hands of those who receive it, as it should be. Now, I'm going to just put forward, this is in the handout that you have from our Public Policy Institute, 5 elements that we like to talk about in terms of describing what person and family-centered care is. And the first is respect and dignity for the older person and his or her family. to listen to and honor the person and family's needs, values, preferences, and goals of care, asking what is important to you, and also asking the family caregiver, how are you and what help do you need? Second element is recognizing the whole person. Again, getting away from that medical healthcare term of patient and looking at the whole individual, including care and support that is integrated within the healthcare and long-term services and support systems, acknowledging the individual in the context of their relationships, especially with their own family and friends, and emphasizing the person and family's well-being, taking into account physical and mental health, spiritual needs, cultural traditions, social supports, and the person's engagement in his and her community. The third element of person and family-centered care is assessing and addressing both the individual and the family caregivers' information, care, and support needs, and their experience of care, based on the wants and needs that are meaningful to the individual family. Examples would be wanting, at the end of life, to live long enough to go to my son's wedding, or a wife who may need training on how to do wound care for her husband for fear of doing something wrong and him having to go back into the hospital. Fourth element is promotion of communication, shared decision-making, and empowerment, based on the principle that older adults, their families, and the healthcare and social service providers and professionals communicate together and build trust in ways that support individuals and families and are useful in decision-making. This takes time, and it means that we need to pay for the taking time to listen and to communicate. One of the messages that my friend and new friend and colleague Gail Sheehy, who is here with us in the audience, a prominent journalist and writer on many, many different passages of life, has taught me about the importance of building trust and communicating with the whole healthcare team, particularly at end of life and before death. And the fifth principle is emphasis on coordination and collaboration across care settings, and integrating family caregivers as part of the care team at all settings, in the home, in the hospital. It may be in hospice, it may be in a nursing home or assisted living. And providing tools for the family members themselves, such as having, what a novel idea, one telephone number to call if you need help. When you talk to families, what is the one thing that they need? They just want that one person on the other end of the phone if they're having a hard time to talk to. So my last point in closing is that in a person and family-centered care approach, it's not enough to know what the person and the family want. You need to have a system behind it to support them. There's no point in asking someone's values and preferences if the system can't honor what the person and family want. So the key and the heart and soul is the provision of services and supports that matter most to older adults and their families, particularly at the end of life. Thank you.